So the next speaker I'd like to invite is Professor Wattanasirichaigoon from Mahidol University. So her topic is the challenges of equitable access.
Good afternoon, everyone, and I'm very pleased to be here and share my. It's hard to see the screen, right? Would you mind if I? Okay. I need to see the screen. Thank you so much. I'm very pleased to be here, and this is my first time in Sydney, which I think is a very lovely city, and I will have to come back. And my background is pediatric geneticists, and I start doing the methylation analysis in Thailand over 20 years ago, and that's why we made the early diagnosis of PWS and start seeing a lot of patients with PWS. We also help the patients start the PWS group 20 years ago, and that's the first time I get involved with the patient organization. And my other hat is I also see a lot of patients with rare disease, and even though the universal health coverage in Thailand is pretty good, but not for rare disease. So it's very hard to talk to the policymaker. They tend to think that why not common disease first? Why not infectious disease first? So we need a lot of time talking to them over and over. So that's my other hat. So now we come to my talk. Okay. Right. All right. To give you some fact about rare disease, it is estimated that about 5% of world population are affected with one of rare disease, and 75% of them have a childhood onset. 1/3 of the patient could be found in the newborn in ICU, and 30% of them they might not survive until their 5th birthday if left untreated or undiagnosed. And 80% of rare disease has genetic in origin. There are over 7,000 rare disease discovered. And that's why it created lots of challenge in diagnosis, because it can come in any time and any form. One person can have many organ involvement. And not just for the medical problem, people living with rare disease and also their caregiver often have the struggle with social exclusion, because it's a physical demanding in treating the patient and a lot of economical constraint as well. So I have opportunity to involve in this research, enhancing equitable access for rare disease diagnosis. In that work, we did a review on academic literatures and also policy during 2021 and 2022. And we do a lot of validation by asking the author who were the expert in the field and also familiar with rare disease environment in that regions. We focus on 6 key topics, including the burden of disease, patient journey, and societal impact, related rare disease policy, related rare disease related policy, and also R&D. So interestingly, in general, people might find that rare disease mean the disease with low prevalence, lower than 1 in 2,000. But in fact, there is no unified definition of rare disease. There are over 296 definitions using by over 1,000 organizations across the world. And in few countries, they might use a broader definition relevant to the health policy makers. For example, Thailand, they use the total number of patients also use the severity and the difficulty in access to treatment, and also high economic burden. I think the reason is they want to try to make sure that there could be financial sustainability for the system. So they try to be a bit by bit. There is also lack of epidemiological data, especially in low and middle income countries, because there is few number of specialists and also a lower number of research. All of these challenges had affect the rare disease policy development. And talking about the burden of rare disease, in this slide you may appreciate that there is about 25 to 30 million people affected with rare disease in United States, in Europe, and in Middle East. In Latin America and in Africa, the number is higher. And in Asia Pacific, which is the most dense populations, that is estimated to have 200 million people affected with rare disease. And Southeast Asia only 45 million. When we talk about the economic burden of rare disease, you can appreciate that in United States, in 2020, in 2019, they spent $966 billion that year. And 40% go to the direct medical costs, which mean medicine and other treatment in the hospital. And almost 60% go to the indirect medical costs. For example, they have to travel, and non-medical costs, which cover that the parents or the patient have to leave job, abstain from job. In Europe, right, they spent 10.5 billion euros in 2017. This number is almost doubling as compared to 2012. Because new medicine or new therapy for rare disease are very, very expensive. There is no much number in Middle East and in Africa. In Latin America, there is a wide range of medical expenditure. But the thing is, the average expenditure for one person with rare disease is pretty high, $1,300 per month. And in Asia Pacific, Taiwan spent a lot of medical expenditure as well. And the digit is 9 times higher in 2019 as compared to 2003. And that has created a lot of public discussion about why and how the money goes to as well. So for global rare disease policy movement, UNDP declared a commitment to reduce rare disease burden by suggesting of including rare disease policy as part of the universal health coverage. And World Health Assembly in 2019 also declared their support. And right now there is a Rare Disease International or RDI with the WHO. They try to develop a collaborative global network for rare disease in each region. This is an ongoing process starting in 2020. Right now it has not been finalized yet. So regional rare disease policy. In the US, there is a well-established rare disease policy. In Latin America, there is a varying vastly from very comprehensive one to a very basic coverage, not including rare disease specifically. And in Europe, they share a lot of common policy on rare disease, such as orphan drug designation and also marketing authorization. However, the decision on pricing and funding for rare disease coverage is responsibility of each state member, and that makes uneven access for people living with rare disease in Europe. In Asia Pacific, there are several countries with rare disease and orphan drug act. or rare disease policy without act. For example, Thailand, we have rare disease policy since 2019, but there is no act on that. And India, which is such a big country, they start having national policy for rare disease in 2021. China doesn't have one. But there is a positive side on that because they start setting a criteria standard for National Medical Center for Rare Disease in 2022. And African and Middle East, there is a long way to go. In some, there is a lot of challenge for rare disease. Usually the clinical trial involve a small set of people, which is highly heterogeneous, and oftentimes the low middle income country will exclude. Okay. And genomic research usually underrepresent those from Latin America, African, and Asian countries. There is also a paucity of cost of unit study, which is a very big deal. I myself would like to do this kind of test, but don't know how to do. And it's not easy to find people to work on this as well. So why this is important? Because it could provide the evidence indicating that cost of the treatment scenario is better compared to the scenario of without treatment. Another challenge, I call it WHO effect. For low-income country, which Thailand used to be, some saying from WHO meant a lot. And not until recently that rare disease had become a policy endorsed by WHO. And policy approach and components are highly variable from country to countries. Legislation approach, for example, Rare Disease and Orphan Drug Act, you can find that it's totally different from one country to another. In one country, it may mean facilitating drug development, and in the other country, it may mean to facilitate affordable access for the patient. So even though that we do a lot of study, but there is a lot of detail that need to be considered. There is also competing priority from other health challenges, for example, infectious disease and nutritional disease. I call it an elephant in the room, which means the problem is so huge and important, but no one in the room wants to talk about it because they don't know where to start and what it would bring them to at the end. For myself, I have worked with a lot of policymakers, and I can say that they are afraid of having rare disease policy because they are not familiar with the rare disease. They don't know where it would lead them to the end, and whether or not it's cost benefit and how to measure the benefit out of that. Because most of the benefit will come as a long term, not an acute term that they are familiar with. And how to do a lot of uncertainty of the new treatment, which is very highly expensive, including gene therapy and so on. And the other thing is how they can answer the public. Why not spend limited resource on the common disease with a larger number of populations and cheaper? Anyway, we always have hope and we always work with them. And luckily, fortunately, that they listen. It's difficult, but they listen. And there is a lot of challenge along the rare disease patient journey that I would not go to in the detail. For those who have interest, can go to the paper. So there are lots of opportunity as well. For example, we need to do a disease registry, and national electronic health record can be helpful that we can capture a lot of the diagnosis. And we also need to do a standardization, including the diagnostic coding system. ICD-10 is the current coding system. Usually it doesn't capture the diagnosis of rare disease because it's more of the organ system-based diagnosis. Okay, we also need a new way of cost economic analysis for rare disease, and societal costs should be included in the analysis to ensure the government that this is a high return on investment. And we also need to improve capacity in healthcare professional and also share the limited resource. We may not need, we may not need diagnostic tests in every city, but at least they can send to the center, and patient can get the access to the treatment. Improving and accelerating regulatory and policy change about rare disease is one thing that we need to work with, because it could be a bottleneck for new disease treatment. We can do fast-track HTA evaluations. Increase awareness among healthcare professionals and policymakers, HTA people, and the public is also very useful. Patient engagement is very important as well. We need to make sure that they understand that their voice is louder than the doctors, right? Which is not typical culture in Asia, but we need to help them to understand. And also we need to help them to understand enough about how the HTA and the public health decision-making work, so that they can have the, they can have meaningful discussion on the table at the policy level. Collaboration and partnership globally and regionally, and also among the center in the country is definitely needed. The other words that I learned recently is about alternative financing, because a lot of uncertainty of new treatment, and the government doesn't want to spend for uncertainty. Is there any way to find a way or negotiate with the in pharmaceutical industry, right? If this work in 3 weeks, in 3 months, or in 6 months, then they will pay. If doesn't work, that's free. Some kind like that, right? And that has been on the discussion in under the universal health coverage in Thailand. As for example, gene therapy for SMA, which has been on the discussion. We also need to help the countries get support from international organizations as well. Okay, and this is rare disease community in Thailand. We cannot work alone to make this happen. And I think that's all I can share. Thank you.
Thank you very much for sharing your experience.
Oh, thank you.
One question? Is there any one question? We have enough time for that.
Yeah, thank you so much for that talk. I've attended a few. I've spoken for the Indian Prader-Willi Association, and it's really quite sad to see the disparity in the way we distribute care. I think we can all agree that the character of a society can be judged by how it takes care of its most vulnerable, right? So it's very, on the one hand, I think it's important for us to put in a business or financial case for taking care of folks with PWS, but it's also kind of really upsetting that is the bottleneck here. They are the most vulnerable. It's for anyone to see, right? So how do we reconcile these two conflicting perspectives? Yes, we should make a business case, but again, you're talking about Thailand or India or many countries in Asia. These are collectivist cultures, and they're it's very it's sort of like a picking and choosing of what criteria to use to take care of the sick. So instead of taking care of the very ill, which culturally would be the most obvious choice, they're asking for a business case. How do you reconcile and advocate in such a situation?
So I think every life is matter, I think. Every life is matter, and no one shouldn't be left behind. And in doing so, I think it's really need several voices together. If you say, just as a doctor, if we say PWS is important, the other people might not say this, might not agree, right? But every people say the same thing and show them how it works, how it has been very helpful to the family, which means the family and the patient have to speak for themselves and show that how good they have been after having the early diagnosis and treatment. For example, one of my patients, the mother always, come to the front, asks about her child and how he has developed, and now he's in grade 10, for example, and doing well, not obese, and how he can do the charity work in the community. So I think it's like elephant. There is no one single point that you can start. You have to start on everything that you can because you don't know where the opportunity is. And I think we also need identify patient champions, not one, but several. And also physician champion, not one, but several. You need to work with the others. In my view, in Thailand, rare disease, we do not compete with the other chronic disease. We work with them. We are one of them, they are one of us. So we didn't feel like we are competing each other. Yeah. Thank you.